Good morning, everyone. It's nice to be on the other side of the table, and I'm looking forward to mingling with everyone and catching up with a few people, which I didn't get the opportunity to yesterday. But this morning I'm going to talk about the work that we're doing in cancer across the cancer continuum to reduce disparities for Aboriginal and Torres Strait Islander people. Before I do that, I'd firstly like to acknowledge the traditional owners of the land in which we're meeting today, acknowledge elders past and present, but also acknowledge the many Aboriginal and Torres Strait Islander people and the communities in which you've come from to join with us and be here at this forum. So just briefly, I'm going to give an overview of our strategic approach to reducing cancer disparities between Aboriginal and Torres Strait Islander people and the mainstream population. I'm going to have a particular focus today on the supportive care needs. Whilst it's one of many programs of work, I think it's an important area because it focuses on our psychosocial needs, and I think that's an area that we haven't discussed in depth today, although we did have some discussion about this yesterday in the yarning sessions. Then if we get time, I'm hoping to sneak in some information about our National Indigenous Cancer Network, and we do have a table out the back. So our approach to reducing disparities between Indigenous and non-Indigenous people is through a collaborative, coordinated and strategic national approach to Indigenous cancer research. And we do that through funding we've received through a Centre of Research Excellence, through our National Indigenous Cancer Network, and also through some funding through Cancer Council New South Wales and Cancer Council Western Australia, CACINDA program of work. But we can't do that work without collaboration and coordination and involvement and true engagement with our consumers, with our clinicians, with cancer councils, with service providers and those who are involved in the cancer care setting across the continuum. So it's very important that we continue to have that engagement. So just very briefly, the two main programs of work that are assisting the funding of our research in this area, the Centre of Research Excellence, we call it Discover TT, you may have heard of that. It's funded by the NHMRC. It's a 5-year program of work, and our Strategic Research Partnership Grant, as I said, funded by Cancer Council New South Wales and Cancer Council Western Australia, is really to continue to develop our strategic research partnerships with service providers, clinicians, communities, individuals, and a wide range of other stakeholders. The ultimate aim of these two massive programs of work are obviously to improve survival and quality of life for Aboriginal and Torres Strait Islander people with cancer through this strategic focus on health system performance, but also looking at trying to improve diagnosis, treatment, and the ongoing care through to survivorship for Aboriginal and Torres Strait Islander people. However, that's a long-term goal, and that's going to take many more years than what we have been funded to achieve that. So we've set ourselves some short-term goals, and that's generating new knowledge, ensuring the effective transfer of that knowledge and the research outcomes, developing that through to practice, ensuring that we're continually updating and informing the health workforce so that we're training Aboriginal people in research. We're working with closely Aboriginal hospital liaison officers and informing them sort of about cancer and trying to work collaborative approach. We're also working with clinicians trying to develop the medical and cancer care health workforce about being more culturally appropriate in the services that you deliver. And we're all about collaboration and working together. So we have two main program areas here, and they fit under two broad pathways, and you'll notice that we really don't have much here around prevention because the focus of these two programs of work are really about the pathways and outcomes of care and improving the models of care and service delivery. We have a huge team of people that are involved in this program of work. Professor Sandra Thompson, who was here yesterday, is responsible for 3 programs here in improving models of care. This is on a timer, I didn't realise. Charlie here is also involved and working with us around models of care and service delivery, as are many other people in the room. But today I want to focus on the supportive care needs of Indigenous cancer patients and the projects that we're doing here. But before I do that, Rosemary Knight presented yesterday some information about the national screening programs, and the cervical screening program is one of those national programs. You can see here that N1 is about cervical cancer screening and Indigenous women's participation in that program. We know from Helen Zorbas's presentation and others that cervical cancer incidence is much higher for our mob, as is mortality, and we know survival is much, much less. And so this project is hoping to look at that issue. We're not able to, in the current system, tell us how many Aboriginal and Torres Strait Islander women participate in this national screening program. We can't do that for the reasons that Rosemary mentioned yesterday. The pathology reports don't identify Indigenous status here. So what we're doing is a national data linkage project across Australia, where we're working with every jurisdiction to get every woman, let's just use Queensland as an example, every woman in Queensland who's ever had a pap smear. So we're working with the pap test register to collect that information. We're linking that to cancer registry data to confirm cancer diagnosis. Then we're linking that information to the hospital medical records data to confirm Indigenous status, because we know it's fairly accurate. We're also going to be collecting comorbidity data around that. So through this project, for the very first time, we'll be able to report on, even though the program's changing, I think this is very important baseline information for the government, but we'll be able to report on comprehensively if our women, which we suspect aren't, but if our women are participating in the pap test screen, if they have abnormalities, are they being followed up? We're able to tell the difference between our Indigenous women in participating in the program that develop cervical cancer and those who don't. We'll be able to compare Indigenous and non-Indigenous comorbidities and a whole range of other things through this one project. So that's an example of the extent of each of these little dot points that are there, massive programs of work. And just to put some numbers around it, in Queensland we have that data already. So that means we're looking at records of 1.4 million women in Queensland who've had a pap test. Of that 1.4 million, 29,000 of those are of Aboriginal or Torres Strait Islander descent. And we have a Torres Strait Islander PhD student, Lisa Watt. It's her PhD, and she's going to be focusing on that project and looking at that data. So I know it's not within the scope of what we're doing, but I thought it was very important, given the discussion yesterday, to really spend a couple of minutes talking about that. So supportive care needs is the focus. Now, as we know from yesterday, there are many factors that impact on our mob, okay? We know that there are social cultural issues. We know that there are issues relate specifically to the patient's understanding of cancer, the patient's decision about treatment and who they engage or don't engage. We also know that there's healthcare system issues as well, particularly around communication. And yesterday we talked about the communication between GPs and patients, for example. So it's very, very complex, and there's not one issue. They're all, interrelated in one way or another. But I think if we look at supportive care needs, it's one area of work that we can actually start to bring some of those factors together and look at addressing those. So now I'm just going to talk briefly about what is supportive care needs and what am I talking about. The appropriateness of existing tools to assess supportive care needs, and then the development of a new tool that our team has worked on, and then a trial implementation in the usual care setting, and then talk about our National Supportive Care Needs project. So cancer patients commonly report physical, emotional, social, informational, practical and spiritual needs. This is any patient with cancer. And supportive care is really the umbrella term that encapsulates all that. Supportive care can also happen right across the cancer and treatment continuum. It involves a wide range of services and comprehensive strategies to address someone's supportive care needs. So more specifically, supportive care aims to prevent, reduce and alleviate symptoms of treatment and enhance communication, which we know from our discussions yesterday is particularly important, between patients and clinicians, and assist patients and their family to manage the associated needs with their diagnosis and treatment of cancer. So needs is a little bit different from other sorts of tools like quality of life tools and distress tools, because needs is really the assessment from the patient perspective. It's asking the patient, what are your individual needs? And not only what are your individual needs, what can we help you with? What do you need help with? And that's different from other tools that are used before. It's solution focused and usually involves a multidisciplinary approach. So why do we assess needs? Well, I think it's pretty obvious. It leads to patient improved outcomes. It also improves the quality of service delivery and decreases, in the end, healthcare costs. And so why do we assess Indigenous needs? Well, as we know from yesterday as well and our own experiences, Aboriginal and Torres Strait Islander people present with complex needs, complex health and well-being issues, and patients don't often tell us about those issues unless we ask them specifically about them. We know that early intervention can reduce disparities, and particularly in the cancer care setting, but we also know there are cultural differences in the way Aboriginal and Torres Strait Islander people understand cancer. We know there's differences in the sorts of information, who we consult in our decision-making style, for example, and how we in fact cope with our illness. So needs assessments are used in a variety of settings. They're most important in a clinical setting because they can help monitor individual needs and also work with the patient in adjusting those needs. They can also identify subgroups of people that are most in need, because some of these things are familiar and across all cancer patients. But how do we identify within that broad cancer group which patients or which groups are most in need? They're also very useful because for the services, they can be used as a quality assurance tool. They can show what existing services are there, and if patients are constantly asking about transport but there's no transport service, then it helps them also identify the gaps and the need and the opportunities for planning, and then in turn lobbying for better resources. In the research sense, and this is how we've used it mostly today, is that it helps us quantify the prevalence of needs amongst Aboriginal and Torres Strait Islander people with cancer, identify which are the most common ones and what are those predictors that predict those needs, and it also helps us identify within our own Aboriginal and Torres Strait Islander group which cancer groups, or is it men, or is it women, is it older, is it younger, which groups, or is it more remote or urban or rural, but which subgroups amongst our cohort are most in need. And again, it helps us identify what changes are needed, and most importantly, if those needs do change over time. And of course, we can also evaluate the effectiveness of any interventions. So when we looked at this area and we thought about this many years ago, and I saw Catherine Jacker here yesterday, and she was most certainly involved in these very early discussions, as were some other people in the room, about, well, how do we assess needs? How do we assess the needs of cancer patients in general? So we looked at how that's done in the mainstream population, and so we did a study to talk to Aboriginal and Torres Strait Islander cancer patients. We spoke to their carers, we spoke to health professionals, and we said, what do you think about this tool? It's called the Supportive Care Needs Short Form 34. That's the abbreviation of it up there. So I said, what do you think about this tool? How do you think it meets the needs of our group? And so we did a qualitative study, and from that qualitative body of work, we found that that tool was not suited for our Aboriginal and Torres Strait Islander cancer patients, particularly for those with low literacy. Some of the wording was also culturally inappropriate. Some items were also redundant because we don't often get a choice of which specialist we get to see, because we mostly use public health system, and we have to see whoever it is that's, we're next on the sort of list. And some needs were not covered, such as having an Aboriginal and Torres Strait Islander person to actually talk to once you're in the... We adapted that tool. We actually changed every single item on that tool. We got rid of some items and we added an additional 10 items that covered more specifically the needs of our mob with cancer. And so what we did is we used that tool with the help of, Lila Murison here from Townsville there somewhere, and people up in Cairns, and also here in the Brisbane area. So we used that tool, which was 40 items, covering a range of issues, and across Queensland in those sort of sites to assess the needs. And from that body of work, we recruited 248 Aboriginal and Torres Strait Islander people across Queensland. And I must thank Christina Bernardes, who's also here as well, for her involvement in managing this project. And so we have 57% of those participants were female. The average age was 53 years. 76% were Aboriginal. Most common cancer types were similar to what was presented yesterday: breast, lung, leukemia, and then digestive organs here. These were the most frequent need items. Again, probably not surprising to us, but it's important to quantify this. So 60% of those 248 people reported at least one moderate to high needs. The biggest concerns were around money worries, and then lots of psychological and psychosocial sorts of issues around concerns and worries, feeling down and sad, worry about the results of your treatment, or anxiety, and what's happening at home, who's going to do the work and who's going to help out in the home setting. So then we did some further analysis because we needed a certain number of people to be able to do this. So we conducted an analysis to see if those questions that we were asking were really addressing and asking the right questions. So we did this analysis and we further reduced the tool so it was very specific now. And it was also psychometrically validated. And so now we have 26 items in that tool with one open-ended question. The tool is verbally administered, which is also very different from all other tools, which are usually posted or given to the patient in the waiting room. We have 4 domains you can see here: physical and psychological needs, hospital care needs, information and communication needs, practical and cultural needs. So what we did then, the next step, you can see this is a whole body of work over a series of years involving lots of people. We did this implementation study to see if this tool can be used in the usual care setting. So the aim of this component, just moving along the timeline, was actually to explore from healthcare staff working in the cancer care setting their perspectives, but also patient perspectives about the feasibility and utility of this tool in usual care. We did this study across various sites. We ended up recruiting 36 Indigenous cancer patients, and 10 health professionals actually delivered the tool. We had 4 sites, and I must thank the Alan Walker Cancer Centre staff and the team up there for helping us out in Darwin, Peter McCallum in Victoria, and a whole range of regional centres in southern New South Wales. So we had 4 sites. We looked at the routine use over a 3 to 5 month period, where we actually gave this tool to the cancer care team after we did some training and said, when you have a cancer patient, can you please use this tool to assess their needs? Then we asked the patient immediately after what they thought about the tool and whether they thought it was useful. And then at the end of the study, we also asked the health professionals. So the patients liked being asked about their needs. This is the mean patient acceptability ratings. They thought today was a good time, and they all came at various times along the cancer journey. They found being asked about their needs helpful. More specifically, some of the comments: it made me feel good that someone's showing interest, that there's people out there who are trying to improve things, not only for cancer patients, but for Indigenous people. We also had another female patient say, "This is just a godsend to me because I know I'm going to get some help because it's always been a real battle for me." Across all of the patients, 58% reported moderate to high needs, which is similar to what we found here in Queensland as well. The types of services that those patients were offered are listed here, but you can see emotional support, education, practical help, social work or the Aboriginal Hospital Liaison Officer, the cancer councils and other types of support. When we asked the staff, 8 out of 10 of the staff agreed or strongly agreed that the tool, SCNAT-IP we call it, is useful in clinical practice and they should continue to use it routinely. 7 out of 10 staff agreed or strongly agreed that it's feasible to use routinely and it's easy to score and to interpret, and that they generally found that the patients thought it was acceptable. The interview data when we had this tended to lend towards the staff thinking it was best suited around early treatment, so then we can cover a broader range of issues. So some of the staff interviews, it provides patients with the opportunity to identify their needs that may not be apparent in more casual interactions. It picks up things that would never have come up until we're at a real crisis point. And there were many quotes like this from patients and staff. So then, now that we know the tool can be used in the usual care setting, Christina Bernardes down the back and I and many other collaborators in this room and outside of this room are now taking it upon ourselves to look more nationally at what are the needs of our Aboriginal and Torres Strait Islander cancer patients. And so these are some of the sites that are currently participating in that national study, and most certainly if you're interested in finding out more about this, Christina will be at the NICAN table at the morning tea break. So now just briefly, I want to talk about our translation. As I said earlier on, it's important to do this research and to do this work and to collaborate with people, but we have to find a mechanism of always updating and always trying to translate back. So in collaboration with Menzies School of Health Research, Indigenous Health InfoNet, Cancer Council Australia and the Luicha Institute, we developed the National Indigenous Cancer Network, and I'm just going to spend a couple of minutes talking about this. So the National Indigenous Cancer Network is a national network. It encourages and supports collaboration around Indigenous cancer research and the delivery of services to Aboriginal and Torres Strait Islander people, their families and carers. So it's important for us. So if Raj down here in New South Wales has just done a publication and Charlie's just published a report, our job through NICAN, thanks Jacinta, is to try and then get that information, make sure it's on this website and updated so that everyone in this room and outside of this room knows about it and we can continue to learn and grow from lessons for that. So it has links with other teams, plain language information, a whole range of things, and I encourage you to visit the website. We have this yarning place, which Health InfoNet is most famous for, I guess. Probably not the right word, but anyway. But it's a sharing place. You can get on and write down your information and ask some questions. There's over 140 mob members signed up. We have, like most other groups, a Twitter account, and we're always twittering away. We also have network meetings here. So anyone who's in our network, we send out an invitation to come to our network meetings. Most importantly, we have these two lovely ladies and plus others like them who are our NICAN Ambassadors. NICAN Ambassadors are Aboriginal and Torres Strait Islanders who've had cancer or they have a family member or a friend with cancer. They're passionate about educating our community about cancer. And as a result of our NICAN Ambassador, we held this most fantastic event, awareness event in Musgrave Park down here in Brisbane earlier this year, yes, it's still 2014, where we had over 200 Aboriginal and Torres Strait Islander people and non-Aboriginal people coming together to share stories about cancer. It was a really positive day. It was led by our survivors, walking out front, sharing our stories, getting the message out and educating our communities. And it was held on World Cancer Day, and we're going to continue to do that, and we're hoping to encourage other jurisdictions to do that. And Brian here with the camera would be happy to talk to you about that. The NICAN also has a range of information, brochures, reviews and other information here. And really I just want to finish by saying coming together is really the beginning, and I think it's relevant for us here today. Keeping together is real progress. But really working together to try and make a change is real success. And that's what I'm about, and that's what I encourage. Collaboration, working together so that we can make a real difference for our mob and our communities in the cancer space. And a whole range of acknowledgements here, and probably some people I left off, and I apologise, but thank you very much.